Bring you greetings from Electekweme Federal University Teaching Hospital at Abakaliki, Ebonyi State, Nigeria. I'm a consultant and a lecturer. My name is Dr. Robinson Chukwudi Onoh. I'm to present in this international conference, setting up an endoscopy unit in a low-resource setting. As a way of introducing this, endoscopy in low-resource setting is growing and getting wide coverage and acceptance. And endoscopy generally involves all aspects of medicine, where you have arthroplasty, orthopedic, you have sigmoidoscopy, cystoscopy, and upper and lower GI. In gynecology, our emphasis is on laparoscopy and hysteroscopy. In OBGYN also, fetuloscopy, embryoscopy, and fetoscopy are also other procedures, though they are uncommon. And especially they are uncommon in low-resource settings. Expertise, fund, and maintenance of endoscopic machines are important attributes in setting up and running endoscopic units in a low-resource setting. The cost of setting up an endoscopic unit in a low-resource setting ranges from $20,000 to $100,000 or more US dollars. This is a big challenge. Of course, that cost and other peculiar dominant variables in low-resource setting pose as a challenge in setting up an endoscopic unit. There are numerous types of endoscopic units that could be set up: the hospital endoscopic unit, the office endoscopic unit, the single specialty ambulatory surgical centers, the multi-specialty ambulatory surgical centers. These are different endoscopic units that could set up. The decision regarding which type of facility to be established is affected by the practice, environment, and the local economics, as well as the politics. In a low-resource setting, the hospital endoscopic unit and the office endoscopic unit are usually the ones that are set up, and that's where we will actually dwell in this presentation. In low-resource setting, funding of endoscopy unit setup could be from a private, government, or public-private partnership, mainly. It could also come from non-governmental organizations. It could be as a constituency project, or it could be from corporate organizations as a mission project. In a low-resource setting, mainly the private setup could be as a sole, or it could be joint. Government owned could actually be budgeted. There are basic requirements for setting up endoscopic units. One of the requirements is training. Training is an important aspect in setting up an endoscopic unit. Of course, if you're not trained, you won't know where to set up or where not to set, what to bring in the setup or what not to bring in. So training is very pivotal in setting up an endoscopic unit. Likewise, there should be a team formation comprising the endoscopic surgeon, the nurse support staff, the biometric engineer, and assistant admin and support staffs, and of course the camera and video recorders. These are some of the components that make the team. And the endoscopic surgeon has to be the team lead. There is also need for certification of these team members. There should be a business plan, and the facility and the planning of this setup should also be put into consideration. Likewise, the design. The training. The training could actually be a local training or a foreign training. One important aspect in this training is that there must be a hands-on. It shouldn't be a training where somebody goes and they feel as if he's watching a video. Effort has to be made to understand the ergonomics and to see what can be done using your own hand when you're doing the training. Because when you're undergoing training, you always imagine it's an easy procedure. But when you're given these instruments, you will understand the ergonomics that is required. Accredited Center is advocated for this training. And the training could be for a minimum of 2 weeks, a maximum of 3 months, where one could get fellowship or diploma in minimal access surgery. Of course, training could also be for 1 year, where one could also obtain master's degree. I want to emphasize once again, every team member, starting from the lowest to the highest, which is the surgeon, must be trained. Training has to be encompassed. There has to be a teamwork. There has to be a teamwork. There has to be a team spirit. The team members have to work together with one mind. Everybody aimed at achieving same goal, which is ensuring that the endoscopic procedure is successful and patient is discharged without complication. Another important requirement in setting up an endoscopic unit is the 3 R's of human resource management. They are recruitment. Recruitment has to be meritorious. You have to ensure that people who are recruited are people who want to work, people who are dedicated, people who are committed, people who are disciplined, people who put in their best. And the second component of the 3 R's is retraining. Sometimes it can also be called reward or relationship. It's an important aspect, and effort has to be made to ensure that the training is done, reward system is given, and there should be good relationship within the endoscopic setup. The last of the 3 is retention. Sometimes it's called is retirement. And this is very important aspect of this endoscopic setup. If a staff feels that it can be retained and there could be retirement benefits or packages, that staff will give the best. That staff will not resign halfway when he must have been trained in the system. That staff will want to work and retire in the system. So this is very important so that the setup does not lose trained staff. In endoscopic setup proper, we have to have a dedicated team or unit. Very important, very pivotal. In fact, I cannot mention it enough. There has to be a team. And the structural components of this setup depends on if there is an established hospital or there is no established hospital. Where there is an established hospital, it becomes easy and cheap because endoscopic components just becomes a part that can easily be obtained and attached. But where there is no established hospital, it means that there has to be a complex that will be constructed before the equipment come in. The endoscopic complex consists of these areas: reception area, waiting area for patients and relatives, consultation rooms, secretariat, demonstration rooms or hall, procedure rooms, which can be the theater or the office, the changing areas or changing rooms, central sterile services department or the contamination area, or the recovery room or recovery area, and of course the wards. The theater should contain the endoscopic stock, which could also be called the tower or the cart. And in this, we have the video, which could be a minimum of 1, and you could have up to 5. 1 for the assistant, 1 for the anesthetist, 1 for the trainees, students, or residents, who can also be in adjoining room. Light source, very important, because endoscopy, you need a light to see what you're doing. The camera could be a single or three-chip camera in low resource setting. Single chip may be cheaper. Carbon dioxide insufflator with an attached cylinder, or it could be from a piped carbon dioxide. In low resource setting, the cylinder is preferred or easy to obtain. Suction irrigation machine will also be there. The fluid pump machine will also be there for the hysteroscope. A surgical machine or generator should also be there. And ideally, this should be a component that should have monopolar, bipolar, and of course the hysteroscopy component, so that the power could be generated for all procedure. The problem with all these machines is the cost, especially in low resource settings. This is a diagram showing what the idea is and what has been customized, especially for a low resource setting, especially for the beginners, especially for the private setting that wants to deliver endoscopic procedure to the patients, to the populace. So this is what it could be: refurbished, and some items that are demo are there, and of course you could see the stack or the cart constructed with aluminum and glass. So this is a concept that has been developed by one of us in a low resource setting, and in doing that, he has actually tried to bring up a system of saving costs using improvised items and using some cloned items or demo or locally made products. Typically, the trolley in this was actually constructed locally by a technician. The monitor, he used a television set. The light source, they used a halogen light and a LED pen touch. The camera used a single chip refurbished. The laparoscope, hysteroscope, scissors and forceps were actually gotten as detachable versions, and the operating sheets were actually demos. Likewise, the receptoscopes. The fluid pumping system was actually from a manual cuff pump, or a sterile disposable urine bag could be used for that. And the hysteroscope and laparoscope could be demos. The suction irrigation machines in laparoscopy could actually be the ordinary suction machine with an attachment for fluid, which could be used for irrigation during irrigation, while the suction will be used for suction during suction. The carbon dioxide and oxygen delivery system, you could actually use a cylinder for that, for delivering it. So this is a way of saving costs for beginners, for starters, for private setups that really want to delve into endoscopy, and cost is a challenge. Some of these items could actually be gotten this way so that the procedure could be set up. Of course, in the theater, we also need multi-parameter monitor. We need the oxygen delivery system, which could come from oxygen cylinders. We need adjustable theater tables. Manual is preferred because of electric uninterrupted power supply. Operating light is also important in case there is need for a conversion. An aesthetic machine with capnograph is also needed. Computers, monitors, TVs and DVD and recorders can actually be one or two or more, so that no part of this procedure could be lost. Patient and theater trolleys are also needed, so that we could actually put in our sterile materials there, sterilized materials there. The laparoscopy working instruments include the various needle, the suction machine or irrigation, suction or irrigation cannula, trocar and cannula, the pots, the monopolar instruments, the bipolar instruments, the needle holders, the modulators. All these are actually meant to be kept in an instrument rack or safety cabinet. The harmonics, ligation, sonicision, and laser, and the ventry. These are not common in low resource settings. So, but if government is putting this into budget, this could actually be part of the setup. The hysteroscopic instruments include the full pumping machines, the hysteroscopes of different types, 3 to 5 mm, 30 degrees, 0 degrees, 12 degrees, 60 degrees. Diagnostic sheet, operating sheet, single or double channeled, where you could use your scissors, your graspers, your biopsy forceps, or the resectoscopes, where the monopolar and bipolar electrodes could be used. Of course, if it is budgeted and there is fund, the shaving machine and the modulators could also be used. The common instruments we use, the speculum, the vorcerum, the tenaculum, are also used in this procedure and should be made available. Different sizes. Passman scanner and Rubin scanner for lap and dye test. Uterine manipulators for the laparoscopic hysterectomy, or the laparoscopic assisted vaginal hysterectomy. Then, most of these instruments we're talking about, most of them are not made in the low resource settings. They are not indigenous. So, most of the time, it's either through representatives, second party or third party that they are procured. However, some low resource settings have actually developed reusable instruments like India and China. So in these areas, these instruments could be gotten from first party. The CSSD and sterilizing units are also very important components of this setup. We have to understand that laparoscopic instruments, majority of them are heat sensitive. So because of that, liquid chemicals for cold sterilization are used. The orthostaldehyde, the 2% activated dialdehyde, glutaraldehyde, acetic acid, electrolyte generated agents could also be used. Gas sterilization could also be used using ethynyl oxide. This takes a longer time than the aldehydes. The autoclave machine should also be there for sterilizing the theater materials and the instruments that are autoclavable and the instruments that are not heat sensitive. Recovery room ideally should also be there because some endoscopic procedure requires sedation and anesthesia, and immediately after it, patients need to be monitored till recovery or till they are stabilized. So we need the oxygen, either piped oxygen cylinder. We need the multi-parameter monitors or pulse oximeter, suction machines, resuscitative equipment, and of course emergency drugs should be there. The endoscopic ward, when patients recover, they are transferred to the ward and they need to be monitored before discharge. Cardiac activity, pulse, blood pressure, and oxygen saturation are supposed to be monitored. And it is expected that when these patients are monitored and they recover fully, they can now be discharged. We have to understand in endoscopy, patients don't really stay too long. They can be discharged within 6 to 24 hours, or sometimes just a matter of 24-48 hours they are discharged. Care and maintenance of this equipment very important and has to be regular. The instruments, some of them need to be recalibrated, and some of these instruments need to be repaired and need to be maintained. Some of these office equipment also need to be repaired, and of course the complex where these instruments are need to be maintained have to be kept clean and ensure that it is not filthy. There are challenges in setting up this endoscopic unit. Instrument purchase, instruments replacement, instrument maintenance is one of the challenges. In low resource setting, most of the purchases are by representatives of different companies. It's advocated that the best way of getting this endoscopic instrument is by buying direct from the companies that produce, first party. Another challenge is in procuring advanced and current instruments. In most developing countries, monopolars and bipolars are what is still being obtained. Best option is using harmonic, sonicision, ligation, and of course, the current concept is using Da Vinci, which is robotic machines. These are not common in low resource settings. Power supply is also a very big challenge in low resource settings. And in low resource settings, the power supplies are epileptic, supported by generators that could fail occasionally. It is advocated that in endoscopy, there should be uninterrupted power supply. The hospital setting is also a big challenge. In most low resource settings, hospitals we have are government hospitals. However, it's advocated that for a good endoscopic unit, private setting, mission setting, joint hospital, public-private partnership, and privatized firms could function better and give better services. Patronage and health system payment is also a big challenge. In low resource setting, out-of-pocket payment is what is obtained. And for endoscopy to run smoothly and effectively, the health insurance system will have to come in so that patients can actually come for endoscopic procedures. In conclusion, setting up endoscopic unit requires a dedicated team, requires site selection, requires good financing for the construction and for the equipping of the endoscopic complex. Demos, refurbished items, unbranded equipment could actually be options of obtaining this endoscopic equipment, though the durability and the reliability may be a concern. Of course, locally made, fabricated could also be an option. The challenges and demands of endoscopic setup, they are quite enormous, and they are a big setback in the growth of endoscopy in low resource settings. These are my references. Thank you very much. Thank you.